Well, thank you for having me talk about this very important topic that's near and dear to my heart. So I'm a board-certified radiation oncologist, and I practice in Southwest Florida within the Genesis Care Network. And I'm the director of our breast program at our regional cancer center affiliated with the Lee Memorial Health System. So no disclosures. So this is a very complex topic to address in 20 minutes, but I'm going to try to give a synopsis of some of the problem. And then touch on some solutions, really using the lens of my practice and some of the tools we've found very relevant and helpful to reach some of our more underserved populations. So disparities in healthcare have persisted for decades, and really cancer is no exception. We know that cancer affects all populations in the US, but due to different social, environmental, economic disadvantages, there's certain groups that seem to disproportionately bear the burden of cancer compared to other groups. And this can manifest really across the cancer spectrum. So in terms of measures, whether it's at the beginning of the journey, so incidence and prevalence, or at the end of the journey with mortality and survival data, but also really everything in between, so morbidity from treatment, survivorship, financial burdens of treatment, and even screening rates and stage at presentation. So this is now it's almost 10 years, so somewhat dated slide, but basically it shows for different disease sites, essentially, whether they're low or high, there is a disparity between racial groups when it comes to overall survival. And so when we think of that even though cancer incidence and mortality have overall fortunately been declining over time in the US, why do certain groups still continue to be at an increased risk for developing and dying from cancer? And sometimes this is almost oversimplified as a black-white issue, but truthfully, populations that can experience cancer disparities also include groups that are defined, not just by race and ethnicity, but also by disability, by gender identity, geographic location, rural versus urban, income levels definitely, education levels, sexual orientation, national origin. So, within your community, I assure you there are disparities, and they're often can be overlooked unless we address our own implicit biases. Because we want our advances and all these great interventions that we learn about, especially at a review like this, to be impactful for all our patients, not just some. These are just some different examples. So, for example, despite similar rates of breast cancer, we know Black and African American women are actually more likely than white women to die of the disease. For prostate cancer, even though we've made strides with screening and treatments so that mortality has really declined across the spectrum for all men, still Black and African American men are twice as likely as white men to die of the disease. Women of color are more likely to present with advanced stages of endometrial cancer compared to their white counterparts, and that's accounting for access to insurance, education level. Colorectal, lung, and cervical cancers, we know, have higher incidence and rates of in certain rural communities compared to urban communities. Patients with higher education levels are often less likely to die earlier, so before age 65, of colorectal cancer, regardless of their race and ethnicity. And there are even lower proportions of Black patients who receive surgery for earlier stage non-small cell lung cancer compared to white patients for early stage disease. And there's references for all of these in the slides. But why? I don't think anybody has a linear answer for this, but there's a lot of ongoing research that's being done on how we can improve outcomes for groups that are disproportionately affected by certain types of cancers. And whether that's from designing and implementing culturally appropriate health interventions, or even doing things like improving access to care in clinical trials, or even in the more translational research world, examining genetic factors that may help explain some differences in biology and rates of aggressive cancer. But truly, the root of a lot of healthcare disparities, cancer being no exception, is really multifactorial, but we do have to have an acknowledgement of some social determinants of health as well as racism, and that's very imperative to be able to truly move forward. So, when we think of social determinants of health and their impact on the likelihood of treatment and outcome in cancer, there's this nexus of these three properties, so poverty, social justice, culture, and really these can intercede at any point in the cancer journey, whether we're talking about access to early surveillance for prevention, early detection and diagnosis, or even treatment and then long-term survivorship. These are just some different examples of the three principles and how they can manifest clinically, whether it's poverty, limiting access to health insurance and therefore health information, or social justice in terms of race and cancer-related health behaviors, or being negatively perceived, or having negative biases towards cancer screening, or even different cultural backgrounds that may perceive susceptibility or have different beliefs about risk-taking behaviors. So, it's really complex. And then, of course, language barriers can also play into this. So, where do we stand as a field? ASCO in 2020 made a policy statement on cancer disparities and health equity, and it was very direct in its condemnation of the treatment of communities of color, and called upon members to really confront and address the complex forces and systems that have created disparities in cancer prevention, diagnosis, treatment, and research. And then as a radiation oncologist, I was really excited that ASTRO similarly had a radiation oncology call to action. So, and they were pretty clear. We must place racism at front and center in order to really legitimately begin the work of reducing the primary risk factor of poor health outcomes among Blacks in the US. And they actually name racism as a root of healthcare inequity, and also acknowledge how structural racism has really affected health disparities for Black populations in the US. So this is a really provocative piece written by some doctors, radiation oncologists, all practicing, who I've been fortunate to train under and call friends, that really gets at even a lot of the issues that came up during Black Lives Matter, police brutality, and how that nexus actually interfaces with a lot of communities of color's disparities in terms of their health outcomes, lack of workforce diversity. A lot of these factors are all interacting. And it's a really provocative piece I'd encourage you all to look up. So, now that we know this problem is very complex, we're all coming at it from different perspectives. There's different degrees of it to which it plays out in our different communities. What are some of the solutions? What's something tangible that we can actually do? So, increasing representation in clinical trials is often talked about, and there's a lot of ongoing work behind the scenes to kind of mandate even percentages of minority patients for certain agents in terms of FDA approval. Interestingly, I think a silver lining of COVID is a lot of innovation in terms of our delivery systems. So increasing access with telehealth, and we've used that a lot in our practice, and we'll talk more about that. Social networks, even social media, has really been able to connect patients across geographic regions and across cultural boundaries to be able to find their tribe. And a lot of that, my patients have found that incredibly helpful in terms of creating their own virtual communities to help cope with and get information. And then they bring those questions back to us in clinic, which has been really exciting. And then, if you're able to have the resources at a regional cancer center to have the statistics, the nurse navigation, the outreach infrastructure, you can actually do a formalized community needs assessment and then increase your patient navigation, and I'll talk more about that. So, what is a community needs assessment and how does that increase your patient navigation? So it's actually a formalized survey instrument that you can do, and it basically helps provide community leaders with a snapshot of their local policy systems and health environment that's currently in place. And then with that, it can help you identify kind of as a community areas for improvement. And so then you can help map out a course of action to make tangible health improvements by creating strategies that can be positive and give sustainable changes right in your own community. And the three main categories touched on are policy changes, systems changes, and then environmental changes. And that's the actual reference if you wanted to pull up the instrument. So this is my center, our Regional Cancer Center. And we're in Southwest Florida in Fort Myers. And it's unique in that, in Southwest Florida, we don't have an academic medical center. We're actually still the fourth largest cancer program in Florida, just based on volume of cases. For example, I do a lot of breast cancer. We saw 1,000 breast cancer cases last year. And then Genesis Care, my umbrella organization, which has over 300 radiation oncology and urology practices, has a stakehold in this kind of regional cancer center. But truly, it's a partnership between a lot of different community practices. So for example, our medical oncology is staffed by not just hospital-employed medical oncologists, but also Florida Cancer Specialists is a strategic partner. For radiology, we have Florida Radiology Consultants, as well as Radiology Regional, pathology. So, we have all the disciplines, as well as different private practice subspecialists, breast surgeons, colorectal surgeons. And they all, this is just like Switzerland of medicine in Southwest Florida, come together having multidisciplinary clinics, tumor boards to better serve our community. So as part of the infrastructure, and for breast cancer, for example, we're NAPBC accredited. But for a lot of these community projects that we're trying to do, Lee Health is a safety net health system, and our support services that are available to patients, include nurse navigation, social work, genetic counseling, dietitians, cancer rehab, and all of that can be available to patients with limited resources who are under or uninsured at no cost. And even though the federal level suggests setting 200% for the poverty level to intercede with a lot of interventions, we actually, through philanthropic efforts in our community, are able to set the threshold at 400% and offer a larger segment of our community additional assistance. So these are just some of the different funds that we have. And what's great is that a lot of these philanthropic funds are locally sourced, and then the money's going back into our community in terms of offering additional resources to patients. So whether it's assistance for prescriptions or gas cards or gift cards for essential oils and massage therapy, we're able to offer patients, even those with limited means, all the same resources we're able to offer our more affluent patients. So, kind of deeper dive if you're interested in the health services research component of doing a community needs assessment. So, that's kind of where we are situated in Southwest Florida. Geographically, we obviously are neighbors to Miami, Tampa, where Moffitt is, and then Gainesville is where University of Florida is. And when you do this deeper dive, we're able to not just get kind of population statistics, so like these are our demographics in Lee County, but then we actually break up the region into these 5 areas, these 5 market regions, and they are linked to zip code and socioeconomic status, and they allowed us to really get more granular in some of the patient characteristics in these different subpopulations within our community as a whole. So, like looking at one particular metric, for example, so like prevalence of cancer, when you look at the different market areas, we see that they're somewhat comparable in terms of prevalence of cancer, though some are doing better than others. And then when we look more deeply at Lee County specifically compared to Florida, these are the most common cancers that are represented in Lee County, Florida, where we practice. And then this is just a sample, but we actually go through these metrics for respiratory illnesses, maternal fetal death, diabetes, so all sorts of different health outcomes. But focusing more specifically on cancer, with Lee County, for example, you're able to look at these data and suggest, well, we're doing okay, compared to the Florida norms, compared to the US, compared to the HB 2020 standards for example, women aged 50 to 74 who are getting mammograms. But then you're able to use that geographic data in terms of the different regions within our county to see, well, what's happening in market area 2, where there's a lower percentage of women who are getting the mammograms. And actually market area 2 corresponds to a community called Lehigh Acres that has a large Haitian and also Spanish-speaking population. A lot of migrant workers are in that area. And so kind of using this snapshot, we were able to actually do more targeted interventions, sending nurse navigators into the community, going to churches, doing more public health outreach. And that was actually then, together with also our funding efforts, we're able to provide about 5 or 6 free mammograms every month. And so the combination of increased education and then also the funding to be able to grant the resources has really been able to allow us to increase our access to mammographic screening in this population. So, and this is actually a particular Facebook group that a lot of my patients seem to gravitate towards. So it's basically a community, on Facebook for women of color. And literally women will share their stories. I've had patients in consultation say, oh, in my Facebook group, I already knew about lymphedema therapy and all this great stuff. And it's just really exciting. I mean, there's actually dozens of different subgroups for any solid tumor disease site. But some of these are actually moderated by some physicians. So like I'll post sometimes on this group. And it's great because then you have a little bit more evidence-based, more grounding in, not just Google, but medical facts. But really this is about patient support. And it's great that these communities have kind of formed and are kind of organically growing as another way to increase access to research and also, patient support. So thank you for allowing me to give you kind of a whirlwind in 20 minutes on this very complex topic. But my hope is that even just sharing some of our experience and just planting some food for thought, you'll be able to go home to your clinics, to your communities, and kind of take some of these principles and go forward.
Questions from the audience?
Thank you for that excellent talk. One thing that I am always struck by is the distrust with the medical community in certain populations, especially in the Black population, Hispanic population, rightfully so because of the history of their participation in clinical trials in the past and some of the things that have been done. But I'm curious as to how you handle that conversation when you present a clinical trial to a patient and they start talking about things like, I don't want to be experimented on, or, you know, there's a lot of that in the community, and I think that we need to do a better job about confronting that and having some responses that resonate.
It's a very important point, and it comes up a lot in clinic. I'll add to that another layer of complexity when there's a language barrier, right, between the physician and the doctor. And then there are also some cultures that have somewhat magical thinking, and sometimes, you know, even explaining that you'll still get standard of care, but in addition, there can just be barriers to kind of understanding, you know, what's the purpose of doing this. I think that, you know, one thing that's helped in our community is increased workforce diversity. So in spite of the fact that radiation oncology is traditionally, you know, lives in the basement, a lot of particle physics, a lot of men, you know, we actually disproportionately have quite a few women, quite a few, you know, underrepresented minorities and patients, physicians of color who are from these communities. And so I think I'm able to, not to pat myself on the back or anything, but I do think sometimes when I'm able to talk with a patient of a similar background and kind of give them additional context, that in some sense that for certain patients is able to offer trust. And then other times it still doesn't work, but then rather than that patient, which can sometimes happen from a provider standpoint in terms of implicit bias, you know, being labeled as difficult or not savvy, you know, that can be documented in a more thoughtful way so that doesn't become a badge of shame for the patient. You know, maybe they didn't want to do the trial for other reasons. They can't comply to the rigorous follow-up because they have, you know, 4 jobs and a lot of children and competing interests in terms of extended family members. So there can be other boundaries, I guess, that prevent a patient from wanting to join a clinical trial, and I think it goes both ways. And it definitely is a challenge day to day, but I think more empathy on both sides can be helpful in bridging it at least somewhat.
Thank you, and I have one question from the virtual audience. I think you touched a little bit on it, but what can we do to confront or dismantle systemic injustices in community private practice settings?
That can be tough, and I myself am in a community private practice setting. I think, honestly, just even forums like this, you know, an opportunity to introduce a topic like this in a non-threatening way among colleagues to be able to spark discussions. You know, there are a lot of people who have made kind of disparities research, you know, their academic niche, and there's a lot of great innovative stuff happening, but if it's not being talked about in a lot of communities, it's not reaching the widest audience. So I definitely think even just having the conversations can be helpful. Again, just increasing diversity in workforce, I think, can help with that, because then you can have more ambassadors to the cause, so to speak. And then there's a lot of importance to allies. So I appreciate everyone's time and listening and thoughtful, you know, oops, lost an earring, sorry. Thoughtfully engaging with the topic so that hopefully, you know, we can continue to make strides incrementally. I mean, it's a very complex topic that won't be fixed, but I think we've already, you know, made a lot of progress.